So we're actually going to have Laurent de Kerchove present the next talk. Gebrine is here. He's alive and healthy, but Laurent is such an expert, he's going to talk about fenestrations now.
We share everything, even the talk. Has to be half to half. And he had 3 at the beginning. That is not correct. Again, no disclosure. I think I'm not the only one here who is fall in love with valve repair. It seems to me, of what I've heard. So we discussed the type 2, the prolapse, in our classification, and leaflet prolapse is not equally distributed among the different leaflets, and I already have a word on that. And the right coronary leaflet is much more frequently involved than the 2 others, and you have here the frequencies of what we have observed. And in fact, we can make a correlation between the right coronary cusp prolapse and the P2 of mitral valve, at least in terms of the observation of the prolapse in aortic insufficiency. For the bicuspid valve is the conjoined cusp, which is almost automatically prolapsing in case of AI. Very rarely there is a B-leaflet prolapse. What is the reason? Therefore, it's not completely understood, but probably that the muscular structure supporting those leaflets is one of the reasons, or that those leaflets prolapse more often than the others. Remind that in the mitral valve, the fibrous part of the annulus has less tendency to dilate, and the anterior leaflet is less frequently prolapsing than the posterior, which is sit on an area which is more fragile and prone to distend. And it hasn't been proven for the aortic valve, but maybe this septal muscular part of the annulus may, in a certain way, make that it will influence the development of prolapse on the right side. How do you diagnose a prolapse? You have fundamentally an eccentric jet. You may have cusp billowing, and you may observe a transverse fold in the leaflets, especially in the tricuspid valve. And during surgery, you have very clearly this fold that crosses the middle of the leaflets. You have the free margin, which is dropping below the others, a free margin elongation. We have mentioned that, eventually ruptured or fenestration, more present on the prolapsing leaflet. And if you quantify the prolapse, you have an effective height which is lower than the other and probably less than 9 millimeters. And this is an example of fenestration, and one of them is ruptured. Now, so I told you when you work on this kind of leaflets, they are not normal, especially if you are working in root dilatation. But even in AI, the leaflet's average size is not normal. And you have a difference of from 5 to 6 millimeters between a prolapsing and non-prolapsing leaflets. This gives you an idea of how much you have to plicate it. We know how to make the best ideal valve is to have an effective height at the end more than 9 millimeters, a coaptation length above 4 millimeters, an annulus ideally between 22, 25. I would say the woman 22, the male 24, 25. No, of course, no residual AR, good mobility of all the leaflets and a low gradient. And then you have the more chance that to have the best start and the long-term results for your patient. We haven't invented the central plication or the Gore-Tex, but in 2009 we have described semi-quantitative approach to treat prolapse with both of those techniques, and especially we have described the prolongation of the plication onto the body of the leaflet. And to give you an idea, we go to the transverse fold, because this transverse fold is a break in the leaflet curvature. Before that, there is normal tissue quantity. After the curvature, there is excess. There is not only excess on the free margin, but excess a couple of millimeters to this transverse fold. And that's why we reduce that with this extension of the plication, and it has as another role to reinforce the plication that you have done. Cortex technique is a bit different than how Tirone David has described it, so we go over and over. With time, we have not completely abandoned this technique. We make very strict use of this technique, not anymore on bicuspid valve, but on tricuspid to treat fenestration. I will show you. So this is how we do a central plication in a typically right cusp prolapse in a patient with no root dilatation. You compare the free margin length with the other reference cusp, and when the zone of exclusion is delimited, you do this small running suture with blocked from the transversal fold to the free margin. This is another example in a patient with a normal root and a left cusp prolapse. And you see how this is prolapsing. We start with an annuloplasty, it's an external ring. We perform that relatively rarely in patients with really normal aortic root size. At this time, we were using a simplicity band, again, an invention of our prestigious mentor, Dr. David. Unfortunately, this band is not anymore on the market, so we replaced that with a Dacron strip or a Gore-Tex tube if we do external ring. And you see how the plication is down on the left cusp, and this is the final result with some leaflet resection to shave the leaflet, like we show in the previous presentation, give you more pliability and probably better coaptation. In a 3-leaflet valve, the center of coaptation needs that the 3-leaflet being very pliable. Another case, in a patient with a root dilatation, you see that there is relatively central AI, so you do not expect to have a very clear prolapse, but the dilatation is relatively asymmetric, and if you take the measurements, you see that the 3 leaflets are not equal. They may have the same geometric height, but the free margin can be different. And you will often notice that after the reimplantation, you have the prolapse of the right coronary cusp. So in the same way as in the isolated AI, we plicate the cusp by taking the 2 others as a reference. And comparing free margin to free margin. And this allows you to identify exactly the zone, the length to be excluded. And then you perform like in the 2 previous videos. Now we will look at the effect of cusp repair on our experience. This was published 3-4 years ago, 300 sparing for tri-leaflet valve repair. And cusp prolapse was not predictor of recurrent AI. Severity of preoperative AI has much more impact on recurrence of AI, and also the number of cusp repair. So if you select a patient, look well at the different leaflets. If you think that many leaflets will need a reparation, this is probably too much, but look, the outcome is recurrence of grades 1, more than 1 plus AI, so we choose a very strength outcome to be able to show the difference between 1, 2, or 3 cusp prolapse repair. What about the fenestration? Small fenestration that are not involved in the AI, generally we do not touch on them, and I think that is quite a general agreement. Now, when the free margin are bigger than that, like long marginal fenestration, like illustrated on the picture just above, those are the patients where reinforcement with Gore-Tex suture may be interesting, like as a reinforcement of the free margin. The large fenestration that leave a defect on the tissue, on the leaflet, then those are generally closed with pericardial patch. And of course, ruptured fenestration are always involved in the mechanism of AI, and those need to be repaired with a patch. And if it is very small, it can be done with a reinforcement with a Gore-Tex, because this reinforcements play the role of resuspension of the leaflet. So here's the example of this kind of leaflet with long marginal fenestration that fragilize the leaflet free margin, and this is the case where central plication and reinforcement with Gore-Tex was applied, and this is one of the only indication of Gore-Tex nowadays in 3 leaflets valve repair. An example of patients with several fenestration. Look on the echo, you see that the AI originates from this commissure between the left and the none, which is a frequently diseased commissure. And there was one large fenestration on the left coronary cusp, and a marginal fenestration on the right coronary cusp. So we combine again the 2 techniques, a patch, here autologous untreated patch closed the fenestration, and the Gore-Tex was used to reinforce the right coronary cusp. And this is the final result. Now, example of ruptured fenestration and enlarged fenestration. You see the AI. You see here there was a ruptured fenestration on the right cusp, which was then repaired with a pericardial patch. And in fact, there was another fenestration, large fenestration on the opposite commissure between the left and the none. And you will see how it is repaired with another type of patch. At the end, you see already the final result. For the sake of time, I run the video. We did a David operation. But this big fenestration on the opposite commissure was treated with this butterfly patch that closed both fenestration using one patch that is first sutured to the commissure and then on both sides of the leaflet by trimming it correctly. And then we do the David procedure. So you can observe that the valve repair was done before anything done on the root. So in case we are not happy with our repair, we believe that will not work, we can just take out the valve and do something more conventional. But in this case, it was a root dilatation. It would have been a Bental, but generally, big work on the leaflets for repair like that are done before we do the valve sparing procedure itself. And this is the final result, trivial central AI. Now, Emmanuel Lansac analyzed impact of fenestration a lot in his cohort of patients, and he found that, in fact, there were few impacts on the reoperation, patient with fenestration or not. If the patient had fenestration without any repair on it, or if the fenestration was repaired, there is no significant difference. But you see that the curve, the cumulative incidence of reoperation is always, of course, above the other curve of patients without fenestration. And if you look at a more strict outcome like recurrent AI grade 2 or more, there is a significant difference for patients having fenestration treated compared to patients without fenestration. So to conclude, leaflet prolapse is a frequent cause of aortic insufficiency in isolated AI or associated with root dilatation. The stress fenestration should be repaired principally if they participate to AI mechanism in prolapse or defect. Cusp prolapse repair is technically simple. It's a central plication. I think most of the team are doing that now, and it's helped with the effective height measure in the caliper. If you are a fan of measurement, like I am, apparently it's not the case of my mentor, but Jordan, where is Jordan? Continue your measurement. I'm sure you will be happy to measure your entire life, and I even do more and more measurement, in fact. So yeah, vascular degeneration, of course, is a risk, and that is the limiting factor, of course, of fenestration repair with this kind of material. Thank you for your attention.
Thank you, Laurent.
Okay.